Good evening, respected doctors. On behalf of Palsons Derma, it is my privilege to warmly welcome all of you to this Derma Masterclass. Founded in 1984, Palsons Derma has remained dedicated exclusively to dermatology for over 4 decades. Guided by our philosophy, passionate about dermatology, we strive to bring innovative, quality-driven, and science-backed solutions that help dermatologists deliver the best possible outcomes for the patients. Our vision is to be a trusted partner in advancing dermatological healthcare through innovation, scientific excellence, and meaningful collaboration with the medical fraternity. We are happy to introduce the Derma Masterclass series, an academic initiative comprising 25 webinar sessions designed to systematically cover the major chapters from the dermatology textbooks. Our objective is to provide a platform for academic enrichment through expert-led discussions, clinical insights, and recent advances. In this fifth session, we shall cover update on contact and occupational dermatosis. We are honored to have Professor Dr. Sanjay Ghosh, Professor and Head, Shantiniketan Medical College, West Bengal, with us today. Dr. Sanjay Ghosh is the author of 5 books on dermatology, including Atlas and Synopsis of Contact and Occupational Dermatology, Manual of Rational Skin Therapy and Dermatological Drugs, 201 Skin Diseases, Diagnosis and Treatment, Articaria Step by Step. Former editor of Indian Journal of Dermatology, Dr. Sanjay Ghosh had also won Best Paper Award IJDVL 2007 and 2009. Dr. Ghosh was felicitated with R.K. Paja Memorial Oration QTCon 2013, A.K. Jha Oration QTCon Bihar 2018, NRS 150 Foundation Day Oration 2022, Dr. Dharmendra Memorial Oration IPHA Con 25, Professor A.K. Bajaj Memorial Oration APEOD CODFI 2025, and Best Teacher Award East IADVL Dermacon 25, Jaipur. He was also felicitated with the prestigious Lifetime Achievement Award AAD India Conclave 2024. Dr. Sanjay Ghosh has authored 118 publications and given 220 presentations at different national and international stages. I'm confident that his expertise and insight will make this session highly informative and beneficial for all of us. We look forward to an engaging scientific discussion and a rewarding learning experience. Thank you. And now I have the pleasure of inviting Dr. Sanjay Ghosh to begin today's session.
Good evening, everybody. It is indeed my great pleasure to be here with you to talk on this very important subject, the field of clinical dermatology, update on contact and occupational dermatosis. I'm thankful to you for joining this session, and I also definitely my heartiest congratulations to the Palsons for arranging such very nice, this is, I think, interactive programs. So contact dermatitis, all you know, actually superficial inflammation of the skin by exogenous chemicals interacting on the skin. But this interaction on the skin may not be always from external side of the body. It could be from internal side of the body that I'm coming later on. So this is a form of so now contact dermatitis, all you know, is actually superficial inflammation of the skin from exogenous chemicals interacting on the skin, but this interaction is not necessarily from external side of the body. It could be also inside of the body that I'm coming later. So definitely this is external eczema or exogenous eczema. We all know endogenous eczema like atopic eczema or seborrheic, etc. But most of the eczema, 80% are of this exogenous eczema. So people believe, the doctors and even the patient, that eczema is not curable. This is not true. If you can stop the exogenous allergens or irritant, definitely you can cure many cases of eczema. That you can boost up to your patient. So, like all others, eczema, three phases, all you know: acute, subacute, and chronic. And this acute, oh no, this is a oozing. I call it the crying of the skin. Then subacute is actually less vesiculations, less scaling. So here half crying, and then the lichenified chronic phase, there is hyperkeratosis, no vesiculation. So almost the crying has stopped, but it's continuing. So this is the chronic phase. So again, you all know that contact dermatitis on etiopathogen, we can divide into irritant contact and allergic contact. And contrary to belief, and common belief, that 80% of contact dermatitis are irritant, is much commoner than the allergic contact. So whenever we diagnose contact dermatitis, we should think the irritant contact, not necessarily patient have allergy to that particular product. Now, conceptually, two types of this contact dermatitis, irritant and allergics, they are differ, but they have very close resemblance in the cellular and cytokines profile. Ultimately, the basic difference remains in the antigen specificity. So, this allergic contact dermatitis possesses this specificity, but irritant doesn't have. So, if we can compare this irritant and allergic contact specific, I told antigen specificity, sensitization is required, and genetic predisposition is usually present. But irritant is normally not having, but some cases of irritant nowadays also, certain papers have shown they have genetic predisposition. Pruritus is much commoner in allergic rather than this irritant. Pain and burning are more pronounced in irritant. Vesicles are not common in irritant. And pustules, that is very important diagnostic sign of irritant contact. That is not much common in allergic. Now, irritant contact again can be divided into acute irritant and cumulative irritant. Acute irritant usually from single insult, cumulative from multiple insult. Acute irritant usually caused by strong chemicals, strong irritants, whereas the cumulative is actually repeated weak irritants. And in acute, there is toxic cell damage, whereas cumulative wear and tear going on. And in acute, we'll get the acute phase like acute eczema, erythema, vesiculation, etc. But cumulative from the beginning, it is chronic, lichenified, etc. The demarcation of acute irritant is sharp, and in case of cumulative, it is diffuse. This is the criteria of diagnosis of irritant contact dermatitis, Richel 90. So this I'm not going to details. If you want to know this, you can go to any book. Now this is a case of acute irritant contact dermatitis. Acute irritant contact dermatitis, actually this is from the pain relieving balm. It's very commonly used and that can cause these blisters and others. So this is acute irritant. This is acute irritant in the early phase. The spillover of an acid in a factory ward. You can see the sharp demarcation. This is very common misdiagnosis of this type of cases. And another, this is acute irritant but late phase. This case was referred by a surgeon to me. Actually, she had undergoing the cholecystectomy operation. After few days, she developed this. Actually, the surgeon was horrified and referred the patient to me. But this is the patient fault, not the surgeon fault. The patient was applying some strong antiseptic, so that resulted to irritant contact dermatitis. So this some patient have very much habit of doing this type of antiseptic preparation in any wounds. This is cumulative irritant. This is very common in our housewives. This not housewives, I can tell the housemakers, I can tell nowadays. The tips of the fingers are affected from the detergents, spices, condiments, etc. So this is now we know fingertip dermatitis is very common. Now allergic contact dermatitis, all we know, is a classic delayed hypersensitivity, usually type 4 immunologic reaction, usually mediated by T lymphocytes. Here immune cells play a major role rather than the antibodies. Now this allergic contact dermatitis, we know, is a particular person who are prone to develop this allergy and particularly exposure to particular substance, and it requires and sensitizes face of the particular that substance. Now the allergic contact dermatitis have two phases. First phase, the first contact is sensitization phase, and the second contact, that is elicitation phase. So when sensitization phase happens, if I am say contact with a nickel, so that will require some time, like minimum 4 days, it could be up to 1 year. So first contact won't cause allergy, this sensitive first contact, first exposure of that particular, but elicitation phase, that is immediate. Already patient is sensitized, so latent period is usually 48 to 72 hours. After that patient can, after exposure, can develop this allergy. Now another misconception, let's say one patient is wearing a shoes, both the foot, but developing contact dermatitis single foot. That is possible. Sometimes people are mistaken. Doctors are sometimes they think it is a fungal infection, but unilateral contact dermatitis is possible even by bilateral exposure of particular shoes and others. Now this is very important. People have to understand. This has been developed by American Contact Dermatitis group. It's a very important. It's actually major conception to encompass in the umbrella of allergic contact dermatitis. The allergic contact dermatitis has 3 stages. The first one, where the skin and the symptoms and signs limited to the particularly area of exposure. That is the normal contact dermatitis. Doctors or dermatologists are diagnosis these cases as contact dermatitis. But we have to think beyond that. And that is usually not diagnosed or underdiagnosed. That is stage 2, the regional dissemination of symptoms and signs, lymphatic spread. From the exposed area, it can spread to the local area by lymphatic spread and from the site of application. So you can understand this is very commonly misdiagnosed. Another is stage 3A, that is the hematogenous dissemination of symptoms from a distance. This was previously called E-deruption, but this has been nowadays in pathomechanism wise explained. And another this concept that systemic contact dermatitis, this you have to understand to we can know the full umbrella of allergic contact dermatitis syndrome. But ultimately all these stages can be diagnosed by patch test. That is a very important principal proof. So allergic contact dermatitis syndrome, stage 1 I told localized, that is normally termed as a contact dermatitis, and people know this is the contact dermatitis. Now stage 2 I told lymphatic, local lymphatic dissemination, erythematous or erythema vesicular, erythema multiforme or erythema multiforme like, or urticarial papules and plaques that I'm showing picture later. And stage 3 I already told hematogenous, stage 3A, and stage 3B is the systemic reactivation of contact dermatitis. Now, this stage 1 SCDS, that could have some topographical variation. We know airborne contact, I'm coming later in details. Airborne is without touching. Contact dermatitis, normally people have a conception that is always by contact. Without contact, it can't happen. So, here, without contact, airborne contact dermatitis can happen. And ectopic means patient himself can auto-transfer the allergen. Like one lady using nail polish on the nail, she can affect her eyelids. So eyelid, that nail polish can be cause of allergic contact dermatitis of eyelid. So this is auto-transfer. Heterotransfer, say one person is using hair dye, his wife could be affected. So whenever you are dealing, say patch test you are doing or getting some rash on the female, you can ask, also you have to ask her partner whether using any hair dye, not herself alone. So this is called heterotransfer, and children are very, very commonly affected from this heterotransfer. People is using spray deo, and that can affect airborne allergy to the child. And in this way, chemical vitiligo or chemical leukoderma can also go to by this autotransfer or heterotransfer. And non-eczematous is that people have normally believed that contact dermatitis means always eczema, always eczema. That's not at all true. In many, many cases, this contact dermatitis could be non-eczematous. That I'm coming later on. So this is stage 1. This actually we can see the localized where he's using the shoes. Here he's getting this allergic contact. This is, we can see the lower legs is some allergy and it is going to lymphatic spread. Left side, this is the stage 2. And this is another stage 2 where the local wrist allergy, we can see the vesicular eruptions, erythematous, but that's going to the lymphatics, and here erythema multiforme like lesions on the palm. That is the lymphatic spread, and this erythema multiforme lesions. So erythema multiforme could be a non-eczematous contact dermatitis in some cases. This is another hair dye allergy, and that is going locally by lymphatic spread, but it is urticarial plaques and papules. Localized urticarial plaque. This has been first designated by Professor Dr. C.L. Go of Singapore. They have first gave this name of this entity, and Dr. Go is my very close friend of mine. He has done lots of work, especially Asian country, on contact dermatitis. Now another I told is hematogenous dissemination. Now this stage 2 and stage 3A, this lymphatic and hematogenous dissemination can set in simultaneously. We can get the lymphatic spread, also at the same time we can get hematogenous spread. So here we can see this is our contact dermatitis of feet from shoes, and that is giving rise to this vesicular eruption of the hands. So this was previously called ED eruption. From fungus infection, this ED eruption also happened, but nowadays it's called the stage 3A SCDS. This is the specs of causing contact dermatitis of a child, and that is due to distant spread, flexural, and this is sometimes misdiagnosed as atopic dermatitis as it is happening. So after doing patch test, after stopping nickel, ultimately the patient was cured. So this type of lesion sometimes we prompt to diagnose as atopic, that should be stopped. This is stasis dermatitis, lots of very sensitive skin condition, and from that we can see the distant hematogenous spread happening in the forearm. So we should be very careful on dealing in stasis dermatitis because they are very, very allergy prone. So topical product, I've seen lots of topical product, emollients, topical antibiotic, topical steroid itself. Topical steroid also can cause contact sensitivity, that you all know. So we have to be very careful. Sometimes in stasis dermatitis, I don't give any topicals except sometimes saline wash and very, say, paraben and alanine free topical moisture. Except that, even topical steroid and other thing avoid. And many cases I could cure in this way. Application in stasis dermatitis is very risky. Now stage 3B, that is the systemic contact dermatitis. What should be the features? Features should be first, a previous episode of a well-defined contact dermatitis weeks or even years before. And there could be history of past test positivity to specific allergen or allergen. Now, in our country, past test unfortunately not done in all centers, but that should be done. Then is a documentation of the past test will tell us the contact dermatitis positivity. Now, what we'll get presently? We'll get presently a systemic introduction of specific allergen or cross-reactive allergen by ingestion, by inhalation, or by injection. So that's why at the starting I told the allergen can enter the body from through our inner system, not only from the external side. It could be through ingestion, inhalation, irrigation. So is right to, and this systemic introduction give rise to a generalized skin eruption or symmetrical pattern. Now the difference between the stage 3 and stage 3B should be in case of 3B, presently, that means systemic contact dermatitis, presently there is no contact with the allergen at present. That you have to understand. Previous, there could be history. And what is the difference between stage 3B ACDS, that is systemic contact dermatitis, and adverse cutaneous drug reaction? Here, the difference is that in ACDR, that is the drug reaction, previously there should not be history of topical application of that drug anytime, causing stage 1 ACDS. If that happens, we should term it systemic contact or stage 3B ACDS. Not we should tell that ACDR. This patient has history of ethylene-diamine positivity by past test. Ethylene-diamine was previously in our this contact dermatitis series, that is Indian Standard Battery, but nowadays it has been omitted as not much use. But still in India, it could be due to poor resources. There's a lot of poor chemicals are used, which is not in abundant in their country. So this history of this patient, after injection of aminophylline, this gives severe is that. So this is a case of systemic contact dermatitis. Ethylene diamine cross-reacting with ethylene cross-reacting with our aminophylline. This is another history. Patch test positivity of Peru balsam. Now the patient is having generalized reaction after taking a fruit juice that contains lots of balsam of Peru. So this is systemic contact. Now this is very common. Pompolix we see and diagnosis as pompolix, but now the term is vesicular dermatitis of hands and feet. So here we have to think in different ways. There could be certain systemic contact dermatitis, and very commonly we do patch test in all these cases. And sometimes we get nickel positivity or cobalt positivity, and there we stop this nickel containing food like dark chocolates, nuts, beans, etc., the spinach, etc. And sometimes we get very good reading, and some of the patients are controlled in this way without giving specific drug therapy. And so whenever we are dealing with these cases like non-specific allergy, like extensive eczematous eruption, or vesicular, I just told, pompolix type of lesion, or idiopathic urticaria, or perioral eczema or cheilitis, erythema multiforme, vasculitis, erythroderm, we should have in our mind this difference diagnosis of systemic contact dermatitis. This we are missing in many cases. We think in many cases, but systemic contact dermatitis sometimes we are not thinking. The principal causes of systemic contact dermatitis are metals, medications, and definitely food. I just told balsam of Peru, including plants and herbal products. And this happens usually within 1 or 2 days of the exposure. Among these SCD2 metals, most common offending is, I just told, nickel. There's lots of coins, jewelry, tools, etc. And even this mobile and this site, this nickel strip. And canned food, coca, chocolate. So we ask the patient also not to take this nickel utensils. Dr. Vien, very famous contact dermatologist of Italy. So he came to India once and I had elaborate discussion. He told that in your country, your utensils are full of high concentration of nickel. So in our country, we are giving high grade nickels. So that's why we are not getting that of systemic contact dermatitis to nickel. So in our country, yet not possible. But the utensils which are used for the cooking of the food, that are specially graded. So that you can allow, but not the normal taking of food, which is not given in heat. Normal, this glass and plate should not be the nickel, because that's in our country, as per Dr. VN, is a very common source of nickel in our country. And in our country, the girl child at very early age, ear and body piercing done. So from that, nickel sensitivity happened in very early life. And nowadays, we are getting many cases of systemic contact. Many patient, refractory patient, orthopedics implant after the hip fracture. The implant we are sitting just 2-3 days back. One lady I got after this implant, this orthopedics implant, hip this implant. She's having tremendous itching almost all over body, but there is very difficult ones in their country. There is a before doing this implant, they are sending to the dermatologist for testing, but unfortunately, the implant allergen, the kit is not available with us. Their country is available. Cardiac implant, even I have a book that's also written by one lady doctor of Dr. Spain. She wrote a thesis on this cardiac implant systemic contact dermatitis. She presented this book me, and that showing how much cardiac implant is causing the systemic contact dermatitis. So that before cardiac implant, orthopedics implant, so in future probably this type of patch testing with this particularly implant is probably coming, because once you have put that implants, very difficult to remove, and the patient suffering we have seen lots. Now, balsam of Peru is a flavoring agent. It's flavoring agent and sweetening agents very commonly used in many or nowadays very ketchup and everywhere balsam of Peru there. So you should be very careful about this, especially when urticaria can happen with balsam of Peru, and systemic contact also very common. So if you do patch test, you get positivity to fragrance, but not to BOP, that's balsam of Peru. You should avoid both because these are cross-reacting allergens. Cross-reacting allergens you have to understand and you have to be careful. Say neomycin, if you are one patient in allergy, you should avoid sophromycin also because these are cross-reacting allergens. Now, aspartame is an artificial sweetener used by the diabetic patient for sweetening their teas and others. In liver, it is converted to formaldehyde. So, if we get formaldehyde positivity in patch test, we should definitely avoid aspartame because in actually liver it is converted. Diet drinks and this what is diet cokes and others is commonly present, so we should be careful about that. This very important chart is published in Indian Journal of Dermatology by Dr. Bajaj. He has worked lots in our contact dermatitis. So you can take one of the major person in our contact dermatitis Indian field. So this is a good, if you want to go to get this in IJ table 2000, which is a cross-reacting, neomycin is cross-reacting with gentamicin, streptomycin. So you should ask the patient PPD, not only other, some doctors are using paratoluidine. Actually, paraphenyl diamine is cross-reacting with PTD also. So certain companies are promoting hair dye with PTD. That equally, we are doing patch tests with that. We are getting allergy with that. So be careful about using PTD instead of TPD. So these are oral, also chlorperamide, tolubutamide. These are all cross-reacting, artificial sweetener. And also these thiuram, disulfiram, and these are cross-reacting. Cobalt is cross-reacting in vitamin B12, cyanocobalt. We have seen cases that cobalt positivity after taking vitamin B12 injection getting severe allergy. And balsam of Peru I already told. So this is baboon syndrome. I think you know that 1980s is the first term. This was SCT to metals antibiotic can develop baboon syndrome. Erythematous lesion on buttock, inner thighs and axilla, resembling red bottom baboon. These are different classification, La Chapelle, Miara, and Uska, but This in this chart we have conglomerated to one so that confusion will be less. So that I'm not going very details, but because that requires time. But I'm showing a case. This axillary involvement, the 61-year male, eruption on both axillary and perigenital area for last 7 days. History of septic reaction for LRTI last 2 days back. No history of any previous topical or drug allergy. So it is a case of STRIVE, symmetrical drug-related intertriginous and flexural exanthema. So this is a very classical description. Now Hosserman has given 5 diagnostic criteria for SDRIVE. First is the exposure to a symmetrically administered drug, systematically, not topical. Sharply demarcated erythema on gluteal area, on V-shaped erythema on inguinal or perigenital area. Involvement of at least one other intertriginal or flexural localization, usually it is symmetrical. So it should be symmetrical, number 4, and not presence of any symptoms, systemic symptoms and sign. So this acral and anogenetic erythema are commonly reported in this SCD2 medication. STRIVE also reported in children apart from the adults. Male preponderance. Latency period could be few hours to few days. Now I'm coming to another interesting aspect of contact dermatitis. I told there's a belief that contact dermatitis means always contact. This is a very superficial belief. Airborne contact dermatitis that can happen without touching, without directly exposing. It is indirect through airborne. Dust, spray, pollens, volatile can cause by airborne fumes and particles. It could affect face, neck, V area, even covered area. Exposed and non-exposed area could be affected, eyelid could be affected. Axillary and waist lines usually the target. So covered area could be involved. This is very commonly misdiagnosed. And sometimes they are very commonly misdiagnosed as atopic dermatitis. And it is most commonly adult atopic dermatitis. But before that, you have to do patch test. You have to clinico-allergological correlate. Then you conclude whether atopic or airborne. And the rashes are usually generalized. But certain clinical clues are that ABCD, airborne contact, do not spare the shadow area, like submental area. In phototoxic and photoallergic, the submental area are always involved, not always spared, back of the ear, these are spared, but ABCD does not spare these areas. So this is submental area, it is involved in case of airborne contact dermatitis. Now Dr. Bushen is also very famous dermatologist from UK. She came in UK, Bombay, Dr. Jerajani brought her. Very authentic contact dermatitis in the field of, and she has classified that airborne irritant, airborne allergic, airborne phototoxic, airborne photoallergic, and airborne contact allergic. So airborne can cause all types of allergy. So here you need allergic patch test and sometimes photo patch test to distinguish that. Dr. Busher is a very interesting lady. She told me that how your diagnosis, the patch test, the 1+ or say plus minus, how can you recognize in this dark skin? That's his, she was wondering that how we can see this in dark skin. But we are accustomed. From the beginning, we are doing this patch test on the dark skin. So we know that this is this. And always try to see, I'll discuss while patch testing, side lighting is important to diagnose the, on dark skin, the papule. Few papules always we miss. So patch test possibility sometimes missed by some dermatologists. So differential diagnosis of airborne contact, contact and photocontact, systemic contact, I told, atopic dermatitis, I told, seborrheic dermatitis is also sometimes misdiagnosed as. So actually these are airborne contact, and polymorphic light eruption also we should think as a differential diagnosis. So this Parthenium, we all know that Parthenium plants, actually we have to show the picture of Parthenium to the person. Some believe that only it is present in the farmers on the agricultural land, it is only in the near the railway line. It's not true. Urban area and different areas, even very clear area, it is present. It is true that it is more common in the open, but any garden area it could be common, and that flowers, white flowers, that's also often coming in our house through other flowers. That you have to keep in mind. So airborne contact can happen from Parthenium, Xanthium, Chrysanthemum, Helianthus, sunflower. It's very cross-reactive. So whenever you get positive, patch positive to Parthenium, you should urge the patient not to contact with sunflower, and they should not consume sunflower oil, because that can give rise to systemic contact. If the patient positive to Parthenium, then can give rise to systemic contact. And we did this study in urban area, as there are now scarcity of land, but not much Parthenium like a open or say semi-urban or village area. So we here got cement, perfume, deodorants, volatile paint, synthetic glue, more common cause at urban area. And now pattern of Parthenium dermatitis, we think this Parthenium dermatitis always airborne, not that. Chronic actinic dermatitis is common with Parthenium. This is Dr. Sharma, who's HOD of this, but is also a good worker on this contact dermatitis. Exfoliative dermatitis can happen from Parthenium. We have to keep in mind. Lichen eruption, prurigo nodularis. Chronic prurigo nodularis also can from this Parthenium. And vesicular hand eczema, also like a nitidus type of eruption we can have. So this is our study, we published it. There we got the positivity with potassium dichromate fragrance, cement, perfume, volatile paint, synthetic glues. So this you have to keep in mind while you are dealing with a case of airborne contact in our urban setup or semi-urban setup. This is a patient not directly contact with cement. He is not a cement worker, but he is actually inspector of that particular factory. So he is on airborne contact with the cement, getting this airborne contact to potassium dichromate. This is airborne, is a housewife residing near a construction point. These are very common, and we are missing this. We diagnose lots of other things, that atopic, etc., but these actually very, very common in this our urban area. So we do patch tests, give positivity and be cautious, but very difficult to cure this patient as the construction is going on for a long time. This is another person, is storekeeper, not directly handling chemicals, but is a fly ash. This Kolaghat, another area, you get lots of fly ash. This actually heaped up outside a factory. So this is a common cause, but directly that area we got lots of patients from this Kolaghat area, that fly ash allergy in local people. They are not directly going to the factory. This is the airborne allergy on inspector paint factory. And this is another nowadays our self-image consciousness due to media advertisement. So people are using lots of deodorant and body spray to increase our self-image. So that is a very common allergen and causing this airborne contact dermatitis. And even you can get chemical leukoderma or chemical vitiline. So this is a forearm allergy, very common from the deodorants and others. So how we can diagnose this airborne contact? Patch and photo patch test. Sometimes we have to do open test. I will tell why we're doing open test. Prick test sometimes needed if we suspect type 1 allergy. And other irritant material to test in other way. So now about patch test. What is patch test? You have all some impression about patch test. In a clinical setting, mini model of an allergy content we have to produce by allergen suspended in a vehicle at non-irritant content. If the vehicle causing irritation, then will be misdiagnosed. So that is a very ideal way. It has almost about 70-80 years patch test has developed. And that patch test is the only scientific proof of any sort of allergy contact. And you can exclude irritant allergy contact. You can exclude atopic dermatitis in this way. So sometimes also we do it to negative that make negative. Number two, that was the probably first evidence-based proof of any dermatological condition apart from the biopsy. So this way we could prove that is a case really from allergic contact dermatitis. Now, if we patch test, either patient can do themselves, that is a self method, uses a road test, repeated open application test, and non-self, that is done by the doctors, is a closed one or open one. It could be done by Finn chamber or true test. I'm coming later. And this Finn chamber and true can be used as a photo patch test. Now, selection of patient is very important. Patient should not take more than 15 mg of oral steroid. Patient should not apply topical steroid on the back for at least 1 week. And not having recent flare-up or active disease, especially on the back, and not recent have any sunburn or photo damage last 2 weeks. But oral antihistaminic you can continue during this treatment. But if you do quick test or if you do open patch test, you should not allow oral antihistaminic. Now, what are the indication of patch test? First is all types of allergic contact dermatitis syndrome, definitely you could go for patch test. Atopic dermatitis, because sometimes atopic dermatitis you have to exclude in this way, or sometimes atopic dermatitis have secondary contact. I've seen patients of atopic dermatitis after treatment not healing, but I do patch test, I get some allergy and I removing that, the patient is much better. So atopic previous belief was that atopic dermatitis have less contact dermatitis, but this is now completely overthrown. Atopic dermatitis more chance of secondary contact. Even psoriasis, as the barrier function is disturbed, psoriasis may have more secondary contact. Namular dermatitis is sometimes a manifestation of systemic contact dermatitis, or it could be secondary contact. Seborrheic dermatitis, I told it can mimic airborne contact. Steatotic eczema also, stasis, I told very prone to develop allergic contact. Eczematous lesion around leg ulcer, that's another very vulnerable area. Leg ulcer sometimes do have secondary contact, that's why not healing. Many cases of leg ulcer I could control or cure by just withdrawing all topical applications. All topical application is detrimental for this. This is a very basic thing. Pompolix you can do and lichenification. So we have to do this LaChapelle and this MyBab 2003 from American contact group. They tell that many cases are having this secondary contact damage. So we have to exclude that. Now this restriction, all you know, patient should avoid tight coat. That I'm not going details before tooth, but this fin chamber, that also I think you know. This is actually the tray we do. But one thing regarding patch test, until you are in front of the person doing the patch test, then you can't learn this. Only by this lecture, it's not all by some workshop. But I believe, or say live workshop, but I believe you should do yourself or get training from some doctor, then actually you will learn how to do patch test. That's very, very essential. Otherwise, very smaller, very finite things you can't understand. And this is a protective foil. This is the actually marking, protective foil removed, and this is the actually applications. If it is a liquid anti-agent, you have to use some blotting paper or filter paper, the drop, but very careful that this application of this allergen should not touch the edge of the fin chamber, because then you can get edge effect that coming later. Again, I am not getting details of the method, but two very important point, only 2 to 3 millimeter of long allergen should be given. Otherwise, it will be too much. So it can give the hyperreaction. And number 2, no allergen should touch the rim of the fin chamber. That's important. Otherwise, you'll get edge effect. And after application of the fin chamber on the back, gentle pressure to be applied. Otherwise, will be the contact only form. This is the actually pressure. You need it. Sometimes some doctors, some center is done by this, not by dermatologists, by technician. That's I think that should not be ideal. The marking is important on the corners, because if you don't mark, sometimes due to sweating in our country, tropical weather, it is being washed out, so you cannot locate the allergens. That's a difficulty. This is our series, Indian Scott-free antigen series, but there are some changes always. So this is the present series. Now this 2 days after, usually we are seeing as per the normal protocol. But this day 4 or day 3 reading is important to actually exclude the delayed reaction. But in our tropical belts, that's important. Many of the patients are not agreeing to patch test due to sweating, another thing, and is really discomfort. So Dr. Go is done good work and is a very good friend of mine. We have a lot of personal communication. So Dr. Go has developed for Asian country 1-day occlusion. After that, we are following sometime in summer months, we are doing this following. After 1 day, you can, then patient is much better compliant, patient is acceptable. And after that, again, you can take the reading 3 days. And after removing 24 hours, you should see the groove. That groove is important. That means actually that fin chamber was properly attached. Otherwise, the reading will be false negative. And always see the reading after removing of the fin chamber 30 minutes after. Other due to the pressure, the erythema, the papule won't be visible if you immediately take the reading. This is a very minute point, but it should be very much important. This is positive response after 48 hours. Second reading could be 72 or 96 hours. But sometimes if you suspect neomycin allergy or corticosteroid allergy, you should be even careful about, even delayed after 7 days you have to read it. This is the positive response after 72 hours. Now, interpretation, all you know is standard, our COT-FEE recommendation or international recommendation. Negative, plus minus means faint erythema, plus erythema papule, non-vesicular. But double plus is erythema papule plus vesicles. 3 plus means erythema, edema, severe allergy, vesicles, gula, even ulceration. RER is irritant. Irritant reaction is usually a charred appearance, it's a burnt out appearance, sometimes even pustule, I told. And NT is not tested. But most important thing is patch test interpretation is the clinico-allergological correlation. Otherwise, you can't conclude. After getting your patch test report, you have to, as a clinician, you have to correlate the patient clinical condition and the allergy and the patch test report. Current significance, if you get present exposure of the allergen and you are getting positivity accordingly, so you can write it is a current significance. But past significance, when patient had history of previous, say, patient has history of previous, say, nickel, but now not taking nickel. So now it is getting, then you can diagnose as systemic contact dermatitis to nickel from the oral some systemic nickel exposure. Past exposure, patient is not having, so it can give a positive result, but presently no significance. And sometimes you cannot explain in any way, so you write down unknown. So this is the most important part of patch test evaluation. Now there are some cause of false reaction. Sensitive vehicle itself will be reaction, so you can get many reaction, increased concentration, impurity, irritant vehicle, and current or recent dermatitis. Then you can get false positive, and adhesive tape dermatitis due to adhesive reaction, angry back syndrome. This is one very strong positive. Say neomycin, you get 3 plus positive reaction. So surrounding area you can get few area rashes. So this is angry band. These are false positive. And number 2, age effect. Age effect means if you are not properly applying the material, so we can gauge age effect in the border. You can get false positive reaction. And sometimes false negative if you can't apply, if you are not firmly applying, you can get false negative result. So these are very sensitive, and I tell usually to my student, this is an art, not only a science of doing patch test. So this is actually the vehicle, that is a Vaseline causing allergy of many reactions. Now complication of patch test is usually a very safe procedure. Complication almost till for last 40 years I am done almost 40,000 patch tests. Hardly one patient has complained anything, very except few. So you can safely do it in your own, even on your office. You can no need of any big center. So contact is for micropore adhesive. So that's why we are using the company name. I'm telling this 3M, that is an American company. That adhesive is better. Other leukoplaster you can't rely. And sometimes discomfort. Sometimes the dermatitis can be explained. It's a recall reaction. Angry back, I already told, or excited skin syndrome. Sometimes persistent patch test reaction, pigmentary change. Very rarely bacterial, I hardly got it. Are extremely rare anaphylactic, but this I never got. So many patch tests I did in my life, and so many patch tests I have advised. Except contact urticaria, you should be careful about big patch tests. That I'm telling. contact dermatitis to adhesive. You can see if you don't use proper quality of micropore, it can cause allergy. This is a persistent, even after 6 weeks, this reaction is persistent. This is rare, very rare, but it can happen. This is exacerbation of allergy after doing patch test. So this is happened, but very peculiarly I saw this type of patient sometimes cured from that contact surgery after this aggravation. I don't know how, but I've seen in many of my patients. Now, open patch test means it should not be any film chamber, should not be any adhesive, just to apply. Open. So it should be open. It should be open, not any film chamber, not should be any covered with any adhesive. Which patient? It should be all cases of contact urticaria and unknown substance. You don't know the substance. So this is indicated of contact area and unknown substance. And negative open patch test does not preclude that allergy is not there. So, but still you should be careful. Whenever you suspect contact urticaria, if you do patch test, it should be open patch test. Then you can avoid reaction. And semi-open patch test is indicated where you are getting some allergen not included in our standard battery. So that always try to do semi-open. Semi-open means you don't use any film chamber. You directly apply on the back after cleaning and then after drying, and then you use the micropore tape. But no film chamber. So an industrial and domestic material also could do, but very carefully. Normally, we advise the allergen not including our India standard battery and do it. Now, another true, that is thin layer rapid use epiquinate test. That is true, but this is costly and it is a limited number of allergen, and usually our Indian standard battery is not that way producing true tests. So we can't do that because our Indian standard battery is important to Indian patient. But it is user friendly and ready to use patch test. Not much time is required. Rote is that patient do themselves. The doubtful positive patch test, if there is, you can ask the patient to apply twice daily for 5 square centimeter upper arm for 7 days. And if it is positive, you can think that it could be really positive. But users is when patch test you suspect strongly is after using a clothing patient getting allergy. So your patch test is negative even with that material. So you ask the patient to use this clothes repeatedly for a few days. Then actually real environment, sweating, friction damage can tell really having allergy or not. Now again a very important area of contact dermatitis, non-eczematous contact dermatitis. Contact dermatitis always we have impression from our childhood or our say early medical studentship that contact dermatitis means eczema. That's not true. That you have to understand. Say always classic eczema dermatitis may not be presentation of contact dermatitis. And this is interesting paper by Bonamonte that though it is not published, unpublished data, non-eczematous form are slightly more common, 52% rather than the classic eczematous. Now, these are various forms of non-eczematous contact like lichenoid contact, pigmented contact, bullous contact, purpuric contact, erythema multiforme like contact. This is the bangles, nowadays made of plastic materials. This is previously was called pola. That's a bit inerts, but nowadays not available. This is so all are plastic bangles. So this can give rise to the lichen eruption, and we have seen chemical vitiligo from this type of bangles. And now this lichenoid contact usually resembles classic lichen, but there are certain differences. Here papules are larger and scaly. Weak-arms are usually absent. Post-impulpary hyperpigmentation is more pronounced here than classic LP, and mucous membrane is involved less. And histopathologically, this classical LP and lichenoid contact occasionally similar, but there are some difference. Lichenoid CD may get focal hypogranulosis, greater amount of spongiosis, large number of necrotic keratinocyte, pleomorphic cellular infiltrate, plenty of plasma cell and eosinophil, deeper perivascular infiltrate, and less dense lymphocytic infiltrate. That's usually not bad. These are histopathological difference between classic LP and lichen C. These are common cause or contributing factor of this lichen. Previously, color film processes nowadays is all mechanized, but PPD, mass cambrate, these are very common cause. This is a description of a lichenoid contact. You can see the large papules. Very commonly, it is diagnosed as lichen planus, treated in many ways, but ultimately no response. We do patch test, get positivity to PPD or related, and we ask the patient to avoid dark shocks. And this was first reported by Dr. Srinivas from Manipal. That this is very common, that lichenoid contact from dark shocks. Very common school uniform is that dark shocks. This is lichenoid contact, forearm and back. She is in work of fabric paint and glass paint. So oral lichenoid contact, or usually dental filler a common cause, but also we get very commonly patch test positive to balsam of Peru. So you can see after removing many patients are very refractory to treatment, but if we get positive to this patch test, so this oral, this balsam of Peru, this garam masala and others to avoid in the food. Many patients are improved and shower foods. Pigmented contact number is very commonly misdiagnosed as lichen planus pigmentosus or sometimes as erythema discomunica persistens. But all this type of cases need patch test. And these are usually not having preceding itching or eczema. But patch test does not necessarily having this type of pigmentation. It may have an eczematous eruption. More common in our oriental countries. These are lots reported from Singapore by Dr. Go and this National Institute of Skin from this Singapore. So that optical whiteness and others are very common, mass cambrate. So this is from the deodorant and body spray, forearms and the area of the neck. This is the face. This ammoniated mercury very commonly still, though it's a banned product. Previously, this ammoniated mercury was in our series, in our potfish series, but now it is omitted as it is a banned product. But we believe that it is still being used in many of the cosmetics. Fairness cream, I think it is believed, so that patient develop this pigmentation. And this is the dark clothes, the azo dye of the clothes must cause pigmented contact. These are the very common dark colored clothes. And these dark colors go not only this pigmented, sometimes we get lots of allergy, and scrotal dermatitis is very common cause with dark colored clothes. Scrotal dermatitis also needs this patch test whenever it is refractory. This from the specs, we can see frame, again the dye and the forearm, the same patient from oral, but same patient can develop this pigmented contact from different elements in his body from different two areas. But this is interesting. Bullous contact, if is the bullous eruption remain localized, we have to think in differential diagnosis bullous contact dermatitis apart from bullous pemphigoid. But here the histopathologically almost same, but DIF will be negative in this case of bullous pemphigoid. So the cinnamon powder, cinnamaldehyde, potassium dichloronickel. This patient you see recurrent bullous eruption hand and feet, and we did positive to that nickel and cobalt, and this actually wrist, you can see the wrist band was culprit and we removed and ultimately he was cured. Now purpuric contact also we sometimes means we refer to a hematologist, but before that you do hematological all workup, but definitely you should be aware it could be from contact dermatitis. This could be from textile dyes, from topical NSAIDs, etc. So this is actually purpuric contact from wearing a navy blue European contouring dress. This dispersed blue can give rise to this purpuric patch. And sometimes from rubber chappals we get lots of purpuric contact. So by seeing this, don't jump into conclusion this is an idiopathic purpura or thrombocytopenic purpura. Now erythema multiforme like eruption I have already shown. The point of origin is actually eczematous. The peripheral will get erythema multiforme. I have already shown the picture. Mango is a very common cause we see in case of around mouth. So this is, I already shown this picture. This is a vesicular eruption and ultimately give rise to erythema multiforme eruption. This is a stage 2 allergic contact dermatitis syndrome. So this is erythema multiforme give a manifestation of, and also mango we have seen such cases, and Singapore persons also they have reported this. Now this is another very important thing, that contact urticaria syndrome. This is first reported by Professor Maybach and Johnson from US. Probably you know who is Maybach. If Nobel Prize goes to any dermatologist, I think it should go first Dr. Maybach. He's 90 plus nowadays. So recently probably as an expert. So instantly direct urticaria developing direct topical exposure of particular area. And sometime on eczematous area it can happen. So contact area could be immunologic and non-immunologic. And diagnosis should be done by, I told, open passages, not closed passages. Prick test sometimes done, but carefully. Now the lateral latex rubber is very common cause of contact. Even patient can have anaphylaxis. And this is sometimes reacting with certain food like latex banana syndrome. So latex allergy patient should avoid banana. Here you have to do prick test or open passages. Don't do any closed passage. Chestnut, avocado also can cross-react with latex. And this surgical, those who are in discipline of surgery and gynecology or the nursing staff, they are very common this latex allergy. So you can use nowadays nitrile gloves available, or sometimes you can use, and sometimes the starch in the gloves is imbibing the rubber material, latex material. So starch free sometimes help much, but also you can use in hand care synthetic, the sterile gloves underline. And this is the non-empirical contact area. These are the causes. This lady have applied some cosmetic containing balsam of Peru. Balsam is also a fragrance, I told. So develop this contact urticaria. This is the open patch test showing this paraben positivity. Immunologic causes of contact urticaria. Now I'm coming another aspect, the photocontact dermatitis. Photocontact dermatitis is dermatitis produced by some substance only in the case presence of light. Without presence of light, this can't happen. So photocontact dermatitis could be phototoxic and photoallergic. And sometimes this photoallergic contact dermatitis may superimpose on polymorphous light eruption or PLE. So in any case of PLE, when you are dealing polymorphous, you should exclude phototoxic and photoallergic contact dermatitis. There is a difference, photoallergic and phototoxic is like this irritant contact and allergic contact. And usually the photoallergic is more common with topical drug, systemic less, but phototoxic is more common with the systemic drugs. And phototoxic allergic happen 24 to 48 hours after, and phototoxic could be immediate. This is a common cause of this phototoxic dermatitis, cold tar, page, creosote, etc., soraline, and this could cause. And this is a phototoxic contact with person who is working with different dyes in a printing press. So this is phototoxic contact dermatitis. And this is photoallergic contact dermatitis. This is a person using antiseptic, very commonly used triclosan. After using, he is developing this, but after changing, also patient is cured. So whenever you can diagnose this as PLE, but don't first jump into diagnosis of PLE. First, before that, exclude that phototoxicity, systemic drug, topical application. Then you can be sure it could be a PLE, idiopathic PLE. So this patient, after stopping that, show patient improve. Sunscreen sometimes do this photoallergic, very common. They were used to prevent sunlight. So this particularly Cinamax, benzophenols are very commonly photoallergic. So we should be cautious about this sunscreen whenever we are using. This is a lady using this neck and musk ambrate is very common in this pregnancy, causing this photoallergic dermatitis on the back of the neck, these foreheads, the forearms. Now, how we should do photopasties? Photopatch, again, you have to see the test, how it is done. 2 sets. In allergic patch test, you do 1 set. Here you have to do 2 sets side by side. So after 1 day, you have to remove one side and see the reading, and then you irradiate with UVA 5 joules per square centimeter. Then again you cover it, and then after 1 day, 72 hours, again you see the reading. You see the difference. So then you can get which certain substance causing photo positivity or not. Now, indication of photopatch test: any eczematous eruption on light exposed area, and particularly worsening with the light exposure. Take the history properly and do this test. And some authors recommend all photosensitive patients should be done by photopatch test. But one caveat, that photopatch test is contraindicated in systemic lupus erythematosus. We should not do, as per the history. Even I am cautious, the family history of systemic lupus, I normally don't do. And this is the photopatch test done in a patient. Now, occupational contact dermatitis, 30% of occupational injury and 40% of occupational disease are actually dermatological in origin. And 90% of occupational contact skin diseases are actually contact dermatitis. And majority of them are irritant disease. And hands remain the main, actually bearing the burn, hands remain the main culprit. So predisposing factor of occupational dermatitis during the recruitment, it is judged. Atopic dermatitis is very common. Psoriasis also I told, it is from impaired barrier function, acne, systemic disease, stasis, skin color, hygiene. So these are host-related factors. Job-related factor, whether exposure to irritants, allergen, infection, and carcinogen. And now this is a case of Mason, who is using cement, having this generalized allergy from positivity to potassium dichromate. This lady is a textile designer using this azo dye on the textile, getting this reaction. And occupation also a farmer using this rice dust containing these pesticides, very common occupational irritant or allergen. Now, differential diagnosis, definitely many dermatoses can resemble contact dermatitis. So before stamping a diagnosis, the atopic, seborrheic, even psoriasis, we should rule out. Sometimes hand and feet are very commonly diagnosed as psoriasis, started with methotrexate, etc. But before that, you rule out contact dermatitis, irritant contact and allergic contact. And definitely clinical history and important findings and pathological tests. And patch test, I think, even it is psoriasis, hand involvement, feet imaging is required, because psoriasis of the hand and feet have even secondary contact. Now, differential as I told, atopic, seborrheic, psoriasis, tinea infection, and polymorphous light eruption. Now, what are the complications of contact? If you don't treat contact dermatitis, if the patient take it casually, so there could be secondary infection, even lymphangitis, cellulitis, post-inflammatory inflammation, hyperpigmentation or hypopigmentation. So this is a shoe contact dermatitis, but having secondary infection. So this could be a little serious. This is, we can see the contact dermatitis feet from the shoes, giving rise to cellulitis. This is needs hospitalizations. So we have to ask the patient, you should treat this, get the cause, and try to cure it. So complication you can avoid. This is a post-inflammatory hyperpigmentation from a contact dermatitis of the face. So this is cosmetically not acceptable. So you have to do proper treatment and prevention and definite treatment. Now management, as like any eczema, acute you have to do topical lotion, subacute you have to give cream, steroid or pimecrolimus, and chronic you can give steroid ointment or tacrolimus. But long continuous steroids, especially hand dermatitis, that could be detrimental, because if you avoid, after that, what can happen? You can use long continuous, it ultimately causing the damage of the barrier function. So damaged barrier function invite more allergen, more irritant inside the skin. So in this way, you are causing the vicious cycle and causing the ailment to become prolonged. So in between, emollients used liberally, topical corticosteroid you can do if it is declared potent, you can do once weekly, weekend therapy. In between, you can do topical. In between, in certain cases, we have to switch over to tacrolimus so that, or low potent topical steroid, so that you can prevent the damage of the barrier function. Oral antibiotic, oral antihistamine needed, short course of oral, but not very prolonged cases. In refractory contact dermatitis, you can use UVB, narrowband, tuba. Erythropoietin, very good drug for anti-eczema, fingertip eczema, vesicular eczema, or hyperactive, but unfortunately yet not available in our country. 30 milligram daily for, but is highly teratogenic all in all. Azathioprine has been recommended for this airborne Parthenium plus, but Dr. Sharma et al. 100 to 150 daily, and also weekly pulse. But I don't prefer this drug too much. In North India, it is a very common habit of using azathioprine, but I know azathioprine has a lot of side effect, toxicity. I prefer mycophenolate mofetil, is much less toxic, that's also useful. And Parthenium dermatitis unresponsive topical treatment, sometimes oral method is also recommended. So that's also shown by certain Chandigarh PGI. They have shown that azathioprine and methyl are almost equally effective as steroid bearing agent. So I think that can be also tried in certain. I think cost is low, and that's a good study. 22 that oral tofacitinib has been used in refractory Parthenium, because Parthenium is such a thing. Even after pastage, you can't avoid 100%. So airborne contact from Parthenium you can avoid. Now, prevention of irritants and allergy by history and past is very important on prevention of contact dermatitis. And you have to remember the cross-reacting allergies. Sometimes we're asking the patient to avoid pain allergen, but cross-reacting allergens sometimes we are omitting. That should not. Emollient, particularly we have done studies that emollient should paraben-free, lanolin-free, and fragrance-free. Because that should be the earlier emollient, because a lot of paraben and lanolin and fragrance allergy have seen, and after, especially the contact of the face, we have seen after switch over this type of emollient, patient is feeling much better. No need of any topical product or even oral product. And soap substitute, we have to think. Liberal use of barrier cream, not much available in our country, but we can use just normal white paraffin or soft paraffin we can use as a barrier cream. That can be used, or any emollient can be used. Gloves should be used, but we should be careful about rubber gloves. Many patients are allergic to rubber or latex. So in that case, you have to do patch test. Now nitrile gloves are available, we can use as a substitute. And number two, or underlying latex glove, we can use some thin plastic gloves, that is hand care gloves. Now, one important thing that the cement allergy I told is very common in urban areas, semi-urban. These are all hexavalent chromium salt. And again, Dr. VN, this important authority, he told me that in our country, in their country, they have solved the problem by adding ferrous sulfate with that, making it trivalent chromium. Actually, hexavalent chromium we are getting, these are less allergic. But peculiarly, after absorption in the skin, after penetrating the skin, this is becoming changed into trivalent, and that is becoming more allergic. But trivalent chromium, though it's a more allergenic, not penetrating, but that is a costly. So ferrous chloride sulfate adding made it trivalent chromium. But their country, they have made this. I personally have requested some cement companies owner to make it like that, but they're telling our cement will not sell if I give costlier cement. So that is a problem. So India government should legislate that they should make a law that every cement hexavalent to change to trivalent should be done. We are not, we are diagnosis atopic, we are diagnosis different diagnosis, but maybe the cement allergy is causing the main problem. So in our country, that government should take step, as their country, Dr. VN told, this changing should be done. And though it is a costly, ultimately the patient will be saved, the Indian community will be saved. Now, so contact dermatitis prevention, identification and avoiding of irritants. And number three, cross-reacting allergen, we should not forget. Like Parthenium allergy, you should avoid sunflower oil. Many patients have systemic contact. Emollient liver leaf for improving the barrier function, substitute and barrier cream, and definitely gloves. So certain food I told latex banana syndrome I told. Exactly nickel can be I told it could be tin food, spinach, chocolate, balsam peru, citrus food, condiments, pickles, etc. Now all you know this test, Fisher test. Actually, this DMG, dimethyl glyphosate, 2 drops with that you will take and rub the surface of the with this cotton wool tip and get a pink or red color change. This will tell that it is containing nickel on it. Sometimes some shop tell say one speck there's no nickel or some wristwatch no nickel is so they're taking high price, but it may contain actually nickel. So you can test in this way. So management of occultation is not only doctor's job, it is employer's job, worker job, government job, and medical job. And photo contact dermatitis, you can definitely use clothing, etc., sunscreen, but careful about not to use this PAVA and this product. And oral drugs we can try. And so, if you are interested, can go through my this third edition of Atlas and Synopsis of Contact and Occupational Dermatology. This is forwarded by Professor Sanjay Ghosh. Just I met him in this last PGI Chandigarh 2025. So thank you all for patient hearing. And thank you, Ms. Paulson, for arranging very nice interactive session. Thank you.
Thank you, sir. The quiz link is actually live. You can see the chat box. So there I've already posted the link. Please do participate in the quiz. You can also scan this QR code and you will be redirected to the quiz link. Time only 5 minutes. I have reposted the link again. Only 5 minutes. You can scan and also you can participate in the quiz. Only 5 minutes. We'll close it by 9:55. We'll close it by 9:55. Last 1 minute to go. So it's time to close the quiz now. And Dr. Sanjay Ghosh is actually ready to answer your queries. So if you are having any query, you can post it in the chat box. If you have any query, please you can share with us. So if you have any queries, you can post it. And it's time to announce the winner's name. So Dr. Bokshi from GIMSH, West Bengal, he has held the first position. Second, Dr. Rashi Hasija from VMMC Delhi scored 16, and Devdatta Roy from Bardhaman Medical College scored 15. So he is the fastest who has scored 15, and Jiashi Bokshi scored 16, and Rashi scored 16. So that's the quiz score.
Co- Congratulations, all the winners, for hearing very patiently and your keen interest on this particular topic. I think in future life, whenever you will, whether in your practice or teaching or doing research, I think this will help you definitely, because this subject often is not much giving highlighted in our daily say talks and even in the conferences. So I thank you all who do us have today's joined in this very important session. Definitely is a very good. We are delighted, and particularly the special conclusion to the winners. And thank you, and this Palsons Pharma, for holding this thing very efficient way, very methodically, and I think this will help to build the clinical dermatology in its, from the root, and ultimately clinical dermatology will live in this way. So thank you all very much. Good night.
So, good evening, everyone. As we come to the end of this enriching academic session, it's my privilege to propose the vote of thanks. On behalf of Palsons Derma, I extend our heartfelt gratitude to Dr. Sanjay Ghosh for sharing such valuable insights and practical clinical experiences. Your enlightening presentation, backed by your vast expertise, has undoubtedly enhanced our understanding of the subject and will greatly benefit everyone in their clinical practice. I would also like to sincerely thank all the respected doctors and postgraduate students who joined us today. Your active participation and enthusiasm made this session truly interactive and meaningful. We hope today's session has been academically rewarding, and we look forward to your continued participation in our upcoming masterclass series. Once again, thank you, Dr. Ghosh, and thank you to all our esteemed participants for being with us today. Have a wonderful evening. Stay safe and see you at our next session.